And we are live. Dr. Claire Phipps, how are you? And welcome to the Menopause Research and Education Fund series of videos that we do for to keep people informed and up to date with what's going on. And to that end, you are fresh from the BMS conference where there was a lot of interesting information and you've done some posts. So I picked some bits out there out of what you found interesting. So shall I start off with the one that took my interest most as well, obviously, and that was the social media one, the one from the BMJ, which said 2/3 of HRT posts don't align with NICE guidelines, and 71% of those posts have a conflict of interest. That's a kind of extraordinary thing. So basically, what's the lowdown with that one?
I think the summary for that, for me, and actually for a lot of colleagues, was we as menopause specialists and those of us like yourself who are trying to provide evidence-based information, we all just need to be careful about how we're using social media, and what we're posting and what advice we're giving, what we're recommending, what we're promoting as well. So what we need to be really careful of is that we aren't, we're not suggesting any particular one product. We're not suggesting, and many of us are quite careful about that. And I think that was reflected in the BMS lecture.
So just to be clear, this is looking only at healthcare professionals. It's not looking at all the other influencers and people who are posting. This was purely of healthcare professionals' posts.
Exactly, healthcare professionals and what people are posting. Because as we know, there's, I guess you could argue that we should all be looking at what we're posting. We all have a duty. If we're in this space, we have a duty of care to be posting accurate information, regardless of whether a healthcare professional or not. But I think as HCPs, we obviously have more of a duty of care to be posting responsibly. But it was specifically looking at that and how we should be posting and what we should be recommending, essentially. And I think it's always nice. I mean, I know that our indemnity providers, our insurance providers, are often talking about this, and it's I think it was a timely reminder for many of us about having some responsibility in posting. And I know that social media can be a bit of a dark place, and I think we've just got to remember that at the end of this, there is a lot of confusion still out there, and I think we just need to be able to have trusted sources of information, and that's where we come in, and indeed, Menopause Research and Education Fund comes in.
Yes, absolutely. We try very hard to make sure that we are accurate. The thing, if it was purely 71%, if we're purely looking at healthcare professionals and 71% of them are not talking about what's in the guidelines, that's pretty damn scary.
Yeah, and I think we've got to remember that the guideline, that there's a huge amount of variation in the guidelines. Guidelines are there as guidelines, and they are there to provide support frameworks for prescribing, but they are in no way stipulating anything. So we've also got to remember some of this is going to be interpretation of guidelines, and that's going to vary from doctor to doctor, of course. But prescribing guidelines and remaining within safe prescribing guidelines is what we should be promoting, and what I think that, for me, that lecture was sort of trying to get at is just remember what you're posting and how that's going to be received, and
Yes.
how that adheres to current guidelines, and actually what does that mean for you and your indemnity.
Yes, because it could be a little bit scary, because it's very easy to say the wrong thing inadvertently. Just unbelievably easy. Interesting. Well, there you go. The other thing then that really stuck out and is also incredibly timely is the recurrent UTIs. What did they say about that one? That was a really interesting one, because that's a horrible thing to have.
Yeah, so look, we know that recurrent UTIs are a problem, not just in perimenopause and postmenopause, but, the epidemiological evidence is that, most of us will have a UTI at some point in our life. Around 6%, I think, was the figure that was quoted, of UK women will be affected at any one time, and around 2 million women will have recurrent UTIs. So that's quite a significant proportion.
Yep.
And I think what we know is around 60%. So, you know, a significant number of women will experience UTI in their lifetime. And it's costing NHS England a lot of money. You know, there were around
And they can
130.
die of sepsis.
Well, we think there's around 200,000 UTI related hospital admissions in around 23, 24, 24, 25, 600 million in admissions alone. Second commonest cause of antibiotic prescribing in the community, and a major driver of antibiotic resistance, antimicrobial resistance. So we do need to recognise that this is a huge problem. It talked about, and Tim Hillard, who is a consultant gynecologist, talked about why that might be. And, you know, what you and I know is we can't ignore the fact that in perimenopause and postmenopause particularly, we see that recurrent UTI possibly as a result of the lack of estrogen that some individuals have. So particularly if they're not on HRT or not using a topical vaginal estrogen, we know that you know, recurrent UTI is possibly part of the cause of that. And the reason behind that is very similar to if you're getting a UTI in a younger age group. It's the fact that bacteria can track up that urethra, that water tube, and cause an infection in the bladder. There was also some really interesting chat about the urine microbiome. We know now more and more that urine isn't sterile. We always thought that urine was a sterile fluid, but we know that it's not. How that relates to recurrent UTIs, we're still not really clear. But I think menopause, we know, changes and increases susceptibility to UTIs, doesn't it? The thinning of the urethra, the thinning of the vaginal epithelium, that reduced mucosal defense also allows bacteria to take hold a lot easier, and a lot more easier than if you had kind of good levels of estrogen on board.
Yeah. All right. Yeah, the microbiome stuff is a really interesting thing, and just
Yeah.
the number of products that I see these days that are coming on the markets claiming that they're going to, you know, if you eat something, it's going to change your microbiome.
Yeah.
Is it's a growth market. Let's put it that way. Good.
It
That's very,
is.
very interesting. The other thing that's also stuck out was the autoimmune and the overlap in symptoms, because we know that postmenopause women do tend to have the predominant amount of autoimmune conditions in comparison to men. So what does this mean in practice for people?
Yeah, so this was Dr. Arvin Cool's lecture on why menopause is relevant to rheumatologists, and it was another. There are so many great lectures, Fiona, but this is another brilliant one because we know as menopause specialists that there's an overlap, isn't there, between menopause symptoms, rheumatological symptoms, and this crossover is not necessarily one, it's not necessarily another, it's this kind of Venn diagram of overlap. And we know that 75% of autoimmune patients are those that are assigned female at birth. And in lupus clinics, so SLE clinics, around 90% of these are female. What we know is much more complicated than that. You know, there are this share, almost like what he was talking about was like the shared zone of fatigue and cognitive dysfunction, arthralgia, myalgia, this common symptom that we describe as brain fog. But what we need to really be mindful of is asking those core clinical questions. So, are we correctly attributing menopause to menopause? Are we correctly attributing rheumatological conditions to rheumatological conditions? And is there a symptom overlap? And if there is a symptom overlap, how are we going to manage that? And I think that's more about, you know, less working in silos, more collaborative care, more collaborative thinking. Is this menopause? Can I treat it with HRT if someone wants HRT or can take it, or is it better off treated with other medications? But we also know some of these medications that are treating rheumatological conditions can also cause some POI, so can also push you into an early menopause potentially. So that was also talked about alongside, you know, we know that if you have an earlier menopause, then you have an increased likelihood of bone density loss and cardiovascular disease. So there was a lot in that lecture that's probably too much to go into now, but those were some of the key things that I picked up.
Yeah, that's really interesting, actually. The other thing that really will probably be very topical for a lot of people these days is the GLP-1s and menopause. Not
Yeah.
necessarily the slowing of digestion and the changes then in progesterone, because I think we know that quite well. But what about the emerging weight loss data and women and GLP-1s? Did they go into what did they say about that?
Yeah, so what Anis Mukherjee was really good at talking about is GLP-1s and weight in general. And what we know is that obviously, certainly in the UK, but probably worldwide, we're having a bit of an epidemic of obesity. And there's been a lot of fear-mongering and judgment over weight loss medication. And of course, we've got the newer weight loss medication orally now too that was recently released. Um, what she really focused on was thinking about how GLP-1s might help to metabolic health alongside hormone replacement therapy. They're not an instead of or it's just to be thought about, really holistically, and knowing that menopause transition is an independent risk factor for cardiometabolic disease. So thinking about that, thinking about how HRT and incretin therapy, so kind of those weight loss medications interact. There was some trial data, but it was small. There was obviously the guidelines that she co-wrote for the British Menopause Society on how we should be careful about the type of HRT that people are using if they're on Manjaro, and that kind of stemmed from those reports of Ozempic babies. I don't know if you remember that term where there were individuals who are having reportedly unplanned pregnancies when they're on the combined contraceptive pill
Oh, yeah,
and
yeah,
using
yeah, yeah,
GLP-1s. And so that
yeah.
was extrapolated into data to suggest that, we do need to be careful about what we're giving individuals in terms of HRT preparations to protect their endometrial safety. So there was more on that. There was kind of updates on the BMS guidance in terms of dosing structures and how we might dose people and what that might look at. And also there was uh, a good discussion on kind of thinking about muscle loss, so sarcopenia, with these medications, because we know that can also um, go hand in hand with menopause as well. So there was a really lovely lecture on it, and there is more guidance on the Women's Health Concern, and there's obviously good guidance for doctors on the BMS.
Yeah, absolutely. With the sarcopenia, has anybody actually sort of looked at it, particularly in menopausal women, and seen how much, is there a difference in the sarcopenia just generally associated with menopause? That is it worse with the GLP ones unless you really do get in there and start doing some serious exercise? Do we know?
Yeah, I'm not sure of any big studies at the moment. I think lots of my knowledge is around observational data. So we do see muscle loss quite significantly if you're not maintaining weight bearing exercise and strength and resistance training. That is one of the major side effects and downfalls of weight loss medications. I don't know of any huge studies. There's obviously studies on weight gain after stopping uh, GLP-1s, and that's more around visceral fat than it is about muscle gain. So I'm not sure of any big studies, but I do think it's something we all worry about and see observationally as an issue.
Yeah, so my husband's on them, which everybody knows, and he's happy for me to talk about them in public. And he has lost a lot of muscle, and
Yeah,
I'm screaming at him on a daily basis, above and beyond what I would normally scream at him about,
yeah,
to get into a gym and do some exercise, because seriously, it is quite startling the amount of muscle that has gone.
yeah. And I think also, it's their muscle loss, but what we've also got to remember is that um, we don't have lots of really hard and fast data on these yet in combination with HRT. And so we need to remember that lots of our recommendations are sort of almost based on extrapolation and not expert opinion. I mean, obviously experts are getting together and discussing this, but there's not high quality evidence. And I think one of the things that Dr. Mukherjee reflected back on quite nicely was, this unscheduled bleeding and following some sort of national guidance. And we did have a talk from Kristen Manley about some of the updated guidance around unscheduled bleeding and dosing around HRT and the use of GLP-1s particularly. And I think that's what we've also got to remember, is that if you are on a weight loss medication, it may well not only affect your HRT, but it may also affect your other medications you're taking. So it's really important that we know about it, particularly when lots of these medications are prescribed by online private clinics, and there's very many clinics that don't necessarily tell your doctor that you started this. And remember, there's a box to tick, and many people tick that box to say, I don't need you to inform my GP, but please, please do, because it's so important that we take into consideration other drug absorption as well.
Yes, absolutely. And I can also guarantee you that my husband has had no advice on that for the other medications that he's taking. Zero.
It's scary, isn't it? It really is.
Yeah, it is actually. Yeah, it really is. Yeah, because actually I hadn't really thought about him and his medications, but yes, now you come to it, it is actually quite a scary thing. Now, speaking of other interesting things on there, then I'll start actually with the Amy study first of 8,000 women. This is the wonderful Susan Davis and her research from down under. What was the Amy study? What did she find and what did she tell you? Because I think she's got a lot of stuff coming, and this is sort of like the first sort of tranche of data, I believe.
Yeah, so it was lovely to have Prof. Susan Davis there. As we know, she's a fount of knowledge around testosterone and lots of other things. So the Amy study was the Australian Women Midlife Study. I think I've got that right. And it was a community-based study of around 8,000 Australian women aged midlife, so around 40 to about 69, and they were recruited towards the end of 2023 into 2024. And what they did was they used validated questionnaires, collected blood samples, and looked at what really their symptoms were and symptoms findings were by menopausal stage. So once they'd kind of gone through all these 8,000 women, they'd actually I think they finally got to around 6,000 women, which didn't include those who maybe were on a GnRH agonist, or who'd had endometrial ablation, or who'd had a hysterectomy, for example. And they then staged them using the MenQual questionnaire, which is a questionnaire which goes through all the menopause symptoms and quality of life. It looked at vasomotor symptoms, which was the single most distinguishing feature of menopause. So hot flushes peak in late perimenopause, I think it was 4.5 times more likely than premenopausally. Night sweats, and there was some data from the Swan study, which we know Prof. Susan Davies studied previously and released previously. Psychological symptoms was a really interesting one. What she said, and I'm quoting her here, is that these are far less diagnostically useful than what social media suggests. So this is going back to what we hear on social media. Anxiety, poor memory, moderate to severe things like depressive symptoms weren't actually significantly greater in early perimenopause than premenopausally.
So just let me to pull you up on the word greater there. Do we mean as in they weren't worse, or they weren't more of?
So for anxiety, for example, only 1.3 times more likely in early perimenopause versus premenopausally. So you could argue that's still an increase, but is that significant? She didn't think it was. Poor memory, I think, again, I don't quote me on this, I would need to double check this, but I think it was 1.5 times more likely. Depression, 1.5 times more likely, although it might be a little bit less, it might be 1.3 times more likely. So again, you could say that, how much of the psychological symptoms are validated symptoms in perimenopause. Now, I think we all recognize that we see individuals in perimenopause and postmenopause with psychological symptoms. It's something I talk about all the time. So again, this is individualization. This is not right. This is what we found. This is what we must stick to, and we must die by this. This is very much, this is a study. This is one study. Yes, it was a big study, but we do know, and we see observationally all the time, that people do, don't they, complain of these psychological symptoms quite significantly. So it's not something that I'm going to carry forward as, right, this isn't a significant symptom in perimenopause. I know it is, but it's interesting data that was presented, I have to say.
Is there a takeaway message in that then, that when you're discussing with a patient that we're going to put you on HRT because you've got all of these symptoms, and that would make sense, then you may find that it doesn't necessarily help these, because not all of them are related, in terms of just explaining how effective the HRT might be in reducing the anxiety and stuff. Is there a reason then, a way of sort of saying, or is there a logic to that would then say it may not actually, for you might not find your anxiety or whatever it is changes significantly because you had it before? Does that make sense?
It does make sense. I always go back to individualization of the person in front of me. What are they just describing, and what other things are they juggling and spinning in their life? Because obviously perimenopause doesn't just coexist on its own. It coexists amongst a whole host of other things. So whether or not HRT works for somebody is going to be highly individualized, based on so many different factors, based on, that foundation pillar that we always talk about, is what are you doing for your nutrition, your movement, your self-care, your sleep, all of these things. Yeah, look, we don't have the $1 million answer for them, but they are obviously going to play a huge part in if HRT is going to be effective for you. We have to get foundations right first. So I don't think anyone is saying that this isn't going to work, but it does need to be individualized.
Yeah, or at least setting expectations in some sort of way.
Yeah,
Or
setting expectations. Sometimes it is the magic bullet. Sometimes people do come back to me and go, oh my goodness, this is amazing. But more often than not, we have to tweak, we have to move things, we have to change things. We have to adapt to where they are in the cycle, to where they are in the perimenopause. So it's not
and
just
have a toolkit.
Yeah, it's a toolkit, and it's not just cut and dry, really, is it? As we know.
Yeah, there is a question over here that's asking, has she published this yet? Because basically they're asking, is there a link to this study?
Yeah, upcoming. So I think all the studies that she mentioned are upcoming. So I'm not sure that they're out just yet, but I think they will be very soon.
Yeah.
And it's called as you said, it's called the Amy study.
Yeah. And that links quite nicely then into also the menopause and mental health talk, which was saying that basically we need much greater integration with psychiatry, and that sort of peak suicide age of between sort of 45 and 54. And I know there are people who get Davis, sorry, it's just answering the question there. Some people get very upset when you say that suicide peaks between, that menopause is responsible, but it does peak there, and there are obviously lots of other reasons why it may or it may not, so let's not have that argument. But what was the talk about, and what did they say?
Yeah, so on that, obviously we know that both in the UK and in Australia, that is the peak age for suicide, but we can't automatically extrapolate that for causation. There's a strong correlation, but that doesn't equal causation. I think that that talk for me was refreshing, in that more and more psychiatrists are bringing in menstrual health histories into their psychiatric history taking. I did psychiatry as a junior doctor when I thought I wanted to do psychiatry as a profession, and it wasn't something that we ever really asked about particularly. And I am surprised at myself for even saying that. But more and more, we know that obviously, it's not like it's a light bulb, but of course, menstrual health and cycle health will have an impact on our mental health. We know that simply from PMS and from PMDD. don't we? And that idea of reproductive depression. Sorry, I'm digressing, and I've completely forgotten your question now, Fiona.
The question was basically what did she say? I guess between the 40 to 45 age group and the greater prevalence of
yes, thank you. Keep me on track, please.
So I've forgotten about myself.
So I think that one of the things that she was saying is that perimenopausal depression may be slightly episodic, so it may come and go, unlike what we see with more typical depressive symptoms. So those generally tend to come and stay. Another really important point is that many midlife women continue to mask, to cope, to carry on. And so many of our standard questionnaires miss that. And we think about kind of midlife depression as, again, what we said earlier, juggling, spinning lots of things, and maybe that's a cause, but maybe we need to think outside the box a little bit. What we do know is that POI, primary ovarian insufficiency, carries, well, this is what was said, was maybe carries an elevated risk. And there's probably a whole number of reasons for that, isn't there? It's a big diagnosis. It comes with an element of quite severe worry, concern, grief around reproductive health. And maybe that needs a bit more attention from mental health services. Again, this is tricky to say because we know that there's restrictions to how people access this sort of care and service. But I think what was coming out was that there's a brilliant new book that they have published. I don't know if I've got it next to me. No, on menopause and mental health, or menstrual cycles and mental health, and it's aimed specifically around psychiatrists to really think about how menstrual health, whether that's menopause or regular menstrual cycles, how that impacts our psychological health.
All right. If people want to find that book, where would they find it? Is it Sophie's new book?
Yes, it is on. I put it on my Instagram feed. It is on there. I'm just having a brain fog moment, and I can't remember.
That's all right. I don't think it's published until August the 10th.
I think it is out because I bought a copy.
Oh, did you?
Yes. So let me have a look.
Because I know she's having a launch in August.
So Menopause, Menstrual Cycles and Mental Health by Sophie Berman.
Yeah.
Yeah. Now I know that they did another big push recently after the BMS because everyone wanted to order it. And I ordered it through a very normal route that you would expect online. And it is available. So I would encourage any doctors out there to have a look.
Yeah.
Anybody, in fact. It's brilliant.
Yes, yeah, Sophie's wonderful. And we are Menopause Support, Sophie, and Menopause Research and Education Fund are currently working on a mental health study looking at suicidality later in the year. We're just trying to get our questions in order at the moment. So that should actually be a really interesting study, I hope.
Yeah.
Then the other thing, I guess, is progestins, not all equal. What did they say about that?
Yeah, so this was Professor Antonio Cano, progestogens and metabolic function. Again, I think this is sort of similar to what we know at the moment in that we try to go for a body identical progestogen if we can, like Utrogestan, because we think that most people will tolerate that best because it is most similar to what the ovaries naturally produce. Now, again, not everybody will tolerate this clearly, and we know that there's going to be some who have progesterone intolerance. But in terms of safety data, we know that thinking about the body identical ones first are probably better from a breast cancer risk. Synthetic progestogens probably increase that risk ever so slightly, but again, that's going to that's going to be based upon your own individual risk, your lifestyle, your weight, your other medical conditions. But not all progestogens are the same. So some people will need different progestogens to control unscheduled bleeding if they've got a family history of breast cancer or if they've had a history of breast cancer themselves. Often we need to think about things a little bit differently, don't we? So what that talk really summed up for me was sort of slightly what we already know, that not all progestogens are the same. Some of them have better metabolic effects in terms of the body identical than the synthetics. But it really it fundamentally depends on the person in front of you, and managing health holistically rather than just thinking about menopause itself.
Yeah, all right. And the last one that now I know nothing about this. Is it With Easy swabs? What are they and how are they changing practice?
Yeah, so with easy swabs, again, don't ask me to tell you what WID stand for. It's a long and complicated genetic test. But these are newer swabs that have become available recently to look at sequences. So if someone has unscheduled bleeding, for example, and we've gone through the process of establishing whether that needs to be investigated or not. The Weird Easy test is a very easy swab, a vaginal swab that can be done of the blood loss from the cervix, and it can look at certain sequences in the DNA of that blood loss that may reflect high risk or low risk for endometrial cancer or hyperplasia. So it doesn't replace other methods at the moment to think about, scans and hysteroscopy and biopsy potentially, but it might be a way that we use a different test, a less invasive test in the future for lower risk individuals, for example. I think, it's a watch this space landscape at the moment because it's not widely available. It's mostly being used privately. I think many clinics are still using it alongside other standard investigations whilst we establish, is it something that we would move to more longer term? But essentially, it's a vaginal swab that looks for the presence of certain markers that might indicate endometrial cancer, and it gives us a low risk or a high risk result.
Brilliant. Well, I mean, it certainly is a lot of very, very interesting information that they had for that weekend. Your brain must have been exploding by the end of it.
It was, I mean, it still is, to be honest with you. I don't think I fully digested everything, so apologies if it all was a bit of a mumble, because it takes weeks, I think, for us to digest all of the information that we learn at the BMS in 2 days because it's just so intense. But hopefully some of that information has come across tonight, and I hope it's helpful.
Yeah, I think so, absolutely. And if people want to find out more about those, I mean, I'm guessing that they can, members of the BMS can find all of this. If they're not, is there any way that they can get hold of these studies or more information on them if they're interested in them?
So with the Wood Easy, there is information online and via their website. And with the other things I've spoken about, I think it will drift into our publications through the BMS shortly as we kind of, gather ourselves from the conference. But the Women's Health Concern and the Primary Care Women's Health Society will have more information as some of this filters down.
Brilliant. All right. And if people want to find you, Possum, where do they find you?
Well, I'm mostly on Instagram and social media now. So I'm a menopause GP, but I'm also at London Gynecology in central London and within the NHS.
Brilliant. Look, thank you for that. And I'll let you go now, and I'm going to go now before I completely melt. You may have noticed I've been sitting here every so often going like this. I honestly think it's probably around about 35 degrees. So there you go. But we survived. That's all that's important. And now we've got the motorbikes going. Lovely. That's a fantastic way to end with a bunch of motorbikes going down the road. Brilliant. Peaceful Ibiza. Come here for a holiday and relax. I will see you soon, and thank you so much again.
No, take care. Nice to see you.
You too.
Bye-bye.